Welcome to the Falcon Pathology Review for USMLE Step 1. The topic for this lecture is joint pathology. Briefly, before we move into considering joint pathology, it is worthwhile to review the basics of joint anatomy. Joints, first of all, can be divided into two main functional groups. There are solid joints that provide structural support and allow for minimal movement. And then there are synovial joints, whose responsibility is to allow a limb to have a range of movement. What one sees in the diagram that's presented here is the typical architecture of a normal joint. An area of bone, with the joint represented by a covering of bone, under which lies the normal synovium, a rim of normal cartilage, and then we also see at the bottom of the diagram an area of eroding cartilage that may be due to the effects of osteoarthritis or possibly an entity such as rheumatoid arthritis. This next slide simply shows a diagram of a normal joint as you see the area of bone with the articular surface of the joint each covered by a rim of hyaline cartilage. The articular surfaces are held together by the joint capsule, and the inner aspect of the capsule is lined by synovium. Synovial cells have a very specific responsibility, and that is to secrete things like hyaluronic acid and glycoproteins, which make the joint surround the joint and make it fluid and mobile. This material also nourishes and lubricates the hyaline cartilage. We now should consider the various forms of pathology that can affect the joints. The main entities here that one is going to want to concern oneself with are the inflammatory and infectious disorders, particularly osteo and rheumatoid arthritis. And your studies here should concentrate on being able to distinguish between these two when one is faced with them on a question on the exam or in a clinical setting. The most common form of arthritis, of course, is osteoarthritis. This is the non-inflammatory degeneration of the articular cartilage due to the wear and tear of daily living. The majority of these cases, thus, are going to be associated with aging, although there is a minority, approximately 5%, that have a predisposing underlying condition. These predisposing underlying conditions can include things such as trauma, so thus one might expect to see osteoarthritis in an earlier age in athletes who have been involved with extensive contact sports, such as football players. Those patients who have a congenital deformity, particularly those with congenital deformities of a particular joint. Diabetics are prone to the development of osteoarthritis, as are obese patients and patients with hemochromatosis. This next slide simply shows an example of the articular surface of a joint that is affected in a patient with osteoarthritis. Note, first of all, the eburnation of the articular surface, the subchondral cysts, and then the underlying region of still viable cartilage and bone. The pathogenesis of osteoarthritis is thought to be an imbalance between matrix production and matrix degradation by chondrocytes. What one sees in terms of the pathology is again demonstrated in the picture here. Note again the granular articular surface. If one looks at this microscopically, you will see osteophytes located in this region of eburnation. There is potentially ossification of the cartilage and joint space narrowing. Clinically, what patients will complain about is a slow, insidious onset of this disorder. They will describe pain that increases with use of a particular joint. They will also discuss with you morning stiffness that does not improve as the day goes along. This will be an important factor to consider if one is trying to distinguish between osteoarthritis and rheumatoid arthritis. In terms of the physical exam, you'll see on your USMLE exams and also when one is on the wards, patients referred to as having Bouchard's nodes and Heberden's nodes. Bouchard's nodes refer to osteoarthritic changes that occur within the proximal interphalangeal joints. Heberden's nodes refer to those osteoarthritic changes that occur at the distal interphalangeal joints. When thinking about the arthritides of immune origin, the main entity that you're going to want to concern yourself with is rheumatoid arthritis. Now remember, with rheumatoid arthritis, you're dealing with a systemic disorder, one that does not just affect the joints, but can also affect the skin, blood vessels, heart, lungs, and muscle. And when one is looking at the joints of a patient with rheumatoid arthritis, what you're going to be seeing is a non-suppurative proliferative synovitis that progresses to destruction of the articular cartilage and ankylosis of the joints. In terms of the populations in which this disorder will present, think about rheumatoid arthritis presenting in women. There's a significant predilection for the female sex with a ratio of approximately 5:1. Also consider this in women that are more in their middle age, between the ages of 40 to 60. The pathogenesis is somewhat unclear, but like many autoimmune disorders, it is thought that there's exposure to some sort of unknown antigen, possibly a microbial antigen, in genetically susceptible individuals. This results in the activation of CD4 positive helper T cells. There's the production of cytokines, including tumor necrosis factor and interleukin-1, which activates synovial cells and induces inflammation that results in joint space destruction and the formation of pannus. There has also been noted in some of these patients the development of IgM antibody to the Fc portion of the patient's IgG antibody present in their serum. Clinically, how these patients are going to present is with areas of irreversible cartilage destruction and a disease that follows an insidious and progressive course. Most damage in rheumatoid arthritis will occur within the first 4 to 5 years after the disease's initial presentation. Thus, it helps to be aggressive with one's therapy early. Small joints tend to be affected before larger joints. Thus, one will see, for example, the MCP joint and PIP joints of the hand affected before larger joints are. Unlike osteoarthritis, patients will describe warm, painful joints where the pain decreases and the joint use improves with activity. Compare that to our osteoarthritic patients who will complain of morning stiffness that does not improve with activity as the day goes along. The X-ray features of rheumatoid arthritis can be quite distinctive. One sees juxtaarticular osteopenia and bony erosions, and then, as we mentioned in a previous slide, the narrowing of the joint space with the loss of the articular cartilage. Remember, as we stressed a few moments ago, rheumatoid arthritis can be seen as a systemic disease. Thus, it can affect skin, blood vessels, heart, lung, and muscle as well. Within the skin, the classic finding is, not surprisingly given the name of this disorder, the rheumatoid nodule, which will present in approximately 1/4 of the patients that have this disease. One will see rheumatoid nodules in areas where there is pressure put on the skin, i.e. the ulnar aspects of the forearm and elbows. You can also see rheumatoid nodules within the viscera, thus look for them around the lungs, pericardium, and myocardium. They appear grossly as firm, non-tender, subcutaneous nodules that, when looked at histologically, have a classic feature of a central zone of fibrinoid necrosis surrounded by a rim of epithelioid-appearing histiocytes. Also, the blood vessels can be affected in rheumatoid arthritis with the presence of a vasculitis, often seen in patients who have very severe forms of this disorder. This slide is simply an example of the sort of radiographic features that one might see in a patient with long-standing rheumatoid arthritis. Again, remember that you can see morning stiffness, but it should improve with use, unlike osteoarthritis. Consider rheumatoid arthritis in patients that have arthritis in multiple joints or arthritis of the hand joints. Remember that the small joints tend to be affected before the larger joints. Also, think about rheumatoid arthritis in patients who present with a symmetric arthritis. This will be important in distinguishing it between both osteoarthritis and some of our other disorders, which we'll talk about in a moment, where there tends to be preferential effects on just a single joint. Also, remember to look at things other than the joints in these patients. Again, look at the skin and consider whether this patient could have rheumatoid nodules elsewhere and possibly a vasculitis. One can measure rheumatoid factor in the blood, and again, look for the radiographic changes that we were talking about, such as the joint destruction and these, as seen here, ulnar deviation of the fingers and the radial deviation of the wrist. There's another form of rheumatoid arthritis known as juvenile rheumatoid arthritis, as the name implies. This appears in a younger age group, generally in females before the age of 16. It can either affect numerous joints or a smaller subset, or can also present like rheumatoid arthritis in a systemic form. Oligoarthritis does tend to be more common in this disorder, one way of distinguishing it from typical rheumatoid arthritis, and also it tends to present more systemically with its initial onset, hence with effects in a variety of organ systems, rather than the effects in the joints that you see initially with rheumatoid arthritis. Rheumatoid nodules tend to be absent here, and rheumatoid factor is negative when one is doing the appropriate blood work. Also, this will be an anti-nuclear antibody, or ANA, positive. Juvenile rheumatoid arthritis had a predilection for going for some of the larger joints, the knees, wrists, elbows, and ankles. The extra-articular or systemic manifestations that one can see is effects on the heart, including a pericarditis and myocarditis. The lungs can be affected by pulmonary fibrosis, kidneys by glomerulonephritis, and the eyes by uveitis. One can also see a rash, hepatosplenomegaly, and serositis. Now we'll move on to some of the rarer forms of arthritis due to autoimmune or immune origin. The seronegative spondyloarthropathies are those disorders characterized by inflammatory peripheral or axial arthritides, where the patient often is HLA-B27 positive. Also, when one is doing the appropriate lab test, one will find that these patients are rheumatoid factor negative, and it's thought, however, that the etiology by which these disorders occur is similar to that for rheumatoid arthritis, that there's a body's immune response to an unknown antigen, thus as these spondyloarthropathies are often seen following a particular infection. The entities that are considered here are things such as ankylosing spondylitis, Reiter syndrome, psoriatic arthritis, and arthritis associated with other inflammatory disorders. Thus, one can see arthritides with patients who have other autoimmune diseases such as ulcerative colitis or Crohn. The ankylosing spondyloarthritis is an inflammatory disease of the axial joints, particularly the sacroiliac joint, resulting in unexplained low back pain. Again, look for this for patients who are HLA-B27 positive. A population that tends to be preferentially affected here are adolescent boys. This is one way to begin looking through the stem of a question and start ruling in or ruling out particular entities if one knows that the answer revolves around some sort of arthritide. Again, if you're dealing with women, if you're dealing with older women, think about rheumatoid arthritis. Younger women, think about juvenile rheumatoid arthritis. If dealing with teenage boys, think about something like ankylosing spondylarthritis. Again, similar to rheumatoid arthritis and juvenile rheumatoid arthritis, there can be extra-articular manifestations, including effects on the eye, uveitis, the heart with aortitis, and potentially amyloidosis. Reiter syndrome is an interesting entity, a non-infectious arthritis of the appendicular skeleton that occurs after an infection, usually a non-gonorrheal genitourinary infection, such as an infection with chlamydia, or GI infections. You'll see this in a specific population, generally males, in between the ages of 20 to 30. Compare this, for example, to what one would see with things such as ankylosing spondylarthropathies or juvenile or adult rheumatoid arthritis. Again, however, there's an association with HLA-B27, with over 80% of the population that suffers from Reiter syndrome being positive for this particular marker. Remember also that Reiter syndrome does not just refer to the arthritis, but refers to a triad of findings. That is the arthritis, the presence of a non-gonococcal urethritis or a history of some sort of GI disturbance, and conjunctivitis. Psoriatic arthritis will affect approximately 10% of the population that has psoriasis. You will see this presenting in patients between the ages of 35 to 45, and it will tend to affect a single joint, often the distal interphalangeal joints, or the ankles, knees, hips, or wrists. Again, unlike things like rheumatoid arthritis, it tends to be asymmetric. One of the classic physical findings on exam for these patients is what is called the sausage finger, due to inflammation of the digital tendon sheaths. Now we're going to deal with some of the different infectious arthritides that can develop in different age populations and groups. Suppurative arthritis can develop from a variety of sources, including bacteremia, general bacteremia, from other sources in the body, or an adjacent osteomyelitis. The organisms are many and varied. They include gonococcus, staphylococcus aureus, particularly in older children and adults. Remember to look for things such as H. flu when dealing with younger children. And again, remember that patients with sickle cell disease are again prone to infection with encapsulated organisms. So if they present with an arthritis, think about organisms such as salmonella. Risks for developing a septic arthritis are some of the things that put you at risk for infection elsewhere. Thus, think about this in patients who are immunosuppressed. Also think about it with patients who have had trauma and may have had direct exposure of the joint space to a particular infectious organism. Also, patients who have chronic arthritis are prone to the development of infectious arthritides, and of course, patients who use intravenous drugs put their system open to the development of not just things such as osteomyelitis, but also infectious arthritides as well. Clinical features, again, unlike some of our autoimmune disorders, here you will see a single joint affected. It will have many of the characteristic findings of infection being warm and red. The patient will present with a fever, and a CBC will demonstrate that they have a leukocytosis and often an elevated erythrocyte sedimentation rate. Draining the particular infected joint will show the typical findings of pus and purulent synovial fluid. The most common form of bacterial arthritis will be gonococcal arthritis. This tends to be monoarticular and most frequently affects the knee. Look for this in questions where you have a single joint being affected, often in a younger individual who will then have to have the history of having some sort of purulent urethritis elicited after complaining of knee pain. Other forms of infectious arthritis to think about include tuberculous arthritis, where one will see the typical granulomas that one associates with tuberculosis here present within the synovium. Also, if dealing with patients that come from the northeastern United States, think about the possibility of Lyme arthritis, secondary to infection with Borrelia burgdorferi. Here you will see the arthritis weeks after the initial onset of the disease. Also, unlike some of our other arthritides, here the arthritis will be polyarticular and migratory. So if you have an arthritis that appears to be going from one joint to another in the patient, think about the possibility of an infectious disorder, particularly Lyme disease. This disorder has a predilection for the larger joints, so look at it moving about from the knees, shoulders, elbows, and ankles. Finally, don't forget, while bacteria tend to play a major role in the development of arthritides, there are also viral arthritides created by things such as parvovirus, rubella, and hepatitis C. The joints can also be affected by various disorders that have a metabolic origin, and the classic of these, of course, is gout. This is a transient arthritis caused by the deposition of monosodium urate crystals within the joints. Classically, the joint that tends to be affected and that patients will complain about is the metatarsophalangeal joint of the great toe. The gout is often the endpoint of various disorders that create a condition known as hyperuricemia. What one sees when one looks at tissue from the affected joint is the presence of urate crystals deposited in the surrounding tissue with a foreign body giant cell reaction creating what is called a tophi. We will show you an example of this in a moment. Urate deposition in the kidney can lead to a gouty nephropathy. Gout, again, is primarily characterized by hyperuricemia, whose primary cause is unknown. Think about gout, however, if you're dealing with a great toe joint that has pain, swelling, and redness that is occurring in a middle-aged man who may describe a family history of having other relatives who are affected by gout. Secondary causes of gout can be due to hyperuricemia resulting from a variety of disorders. Think about hyperuricemia that may result from the various leukemias and multiple myeloma, and also the myeloproliferative syndromes. Leigh-Sheehan syndrome, which you may remember from the genetics lecture, an X-linked disorder that leads to an HGPRT deficiency, presents with gout in children who are also prone to mental deterioration and self-injurious behavior. Pathogenesis of gout, the primary thing that one needs for the development of this order is, of course, hyperuricemia. However, there does appear to be other factors that need to be present for the development of gout within the appropriate joints. You need to be dealing with generally older individuals who are over the age of 25, and again, individuals who may show a genetic predilection to the development of gout. Those patients who abuse alcohol or who are on thiazide diuretics also be prone to developing this disorder. What one sees again is precipitation of monosodium urate crystals, which are negatively birefringent when looked at under polarized light in joints. These crystals are thought to activate chemotaxis of leukocytes. These leukocytes release various lysozymes, which end up damaging the joint and creating pain for the patient. This picture is simply an example of tophi, the central area of the monosodium urate crystal surrounded by a rim of fibrosis with scattered giant cells as the joint reacts to this foreign substance being deposited. Pseudogout is due to the deposition of calcium pyrophosphate in joints. Similar to gout, you will see this in older individuals, generally over the age of 50. The majority of cases of pseudogout are idiopathic. It can be seen in patients who have a hereditary form of severe osteoarthritis with a gene localized to the long arm of chromosome 8. Also think about pseudogout from various secondary causes, that is, patients who for some reason may have abnormalities either within their joints or within their calcium homeostasis. Thus think about pseudogout, for example, in patients where there's been involvement of the joint by trauma, or who have changes in their calcium metabolism due to things such as hyperparathyroidism, or have other changes within their metabolic balance, including conditions such as hypomagnesemia, and who also may suffer from things such as hypothyroidism, onchronosis, or diabetes. Clinically, it will be difficult to distinguish this from gout. One often needs to biopsy the affected joint and have your pathologist determine if there are negatively birefringent crystals there consistent with gout, or whether the material appears more consistent and is not negatively birefringent and thus is more consistent with pseudogout. Then we have to consider the issue of joint tumors. The ganglion cyst may be familiar to some of you as simply a small cyst located near the joint capsule, which often arises in the wrist. One sees this as a firm, fluctuant, pea-sized translucent nodule, just thought to be due to cystic or myxoid degeneration in the connective tissue and has no actual communication with the joint space. The synovial cyst is due to, as the name implies, herniation of synovium through the joint capsule. You call this a Baker's cyst when you see it in the popliteal space in the setting of a patient with rheumatoid arthritis. Pigmented villonodular synovitis is simply a neoplastic proliferation of synovium that usually occurs in the knee in individuals between the ages of 20 to 40. And that concludes this lecture in the Falcon Pathology Review Series for USMLE, Step 1, Joint Pathology.